Hello, everyone, and welcome to the SCCT 2025 Best Abstract Award session. I am Muaz Al-Maleh from Houston Methodist, and I'm honored to welcome you to this session. We have a great lineup of 6 outstanding abstracts that will be presented. Each will be presented over 8 minutes, followed by 5 minutes of question that will be addressed by the panelists that are kindly joining us on this call. So at this time, I'm going to go ahead and introduce the first presenter, and it's Dr. Ravi Shotolia, presenting about, is it safe to defer revascularization in asymptomatic patients with chronic coronary syndrome with FFRCT positive stenosis? Ravi, you're muted. We can't hear you. Can you please unmute?
Hi, can you hear me now?
Yes, we can hear you. Go ahead.
Okay. So, hi there, everyone. My name is Ravi. I'm an academic cardiologist at the University of Lincoln. It's a huge honor to be able to speak with all of you today, and I'm really looking forward to hearing all of the other presentations. The title of my talk today is it safe to defer revascularization in asymptomatic patients with FFRCT positive stenoses? I'm trying to change slide. So, FFRCT, or fractional flow reserve derived from CT, is a non-invasive measure of the physiological significance of a coronary stenosis. Studies have identified in patients with CCS with an FFRCT positive stenosis, which is defined as less than 0.8 distal to a stenosis, who had medical management only, had worse outcomes compared to those with an invasive management strategy. However, these previous studies didn't record the patient's symptom status, and symptom status has also long been shown to correlate with poor outcomes in CCS. Now, ESC, AHA, and NICE guidance in the UK recommends PCI only in patients who are symptomatic on medical therapy, obviously in the absence of high-risk disease. So now FFRCT is being used upstream in clinical practice. Clinicians are faced with patients with FFRCT positive stenoses who may be asymptomatic on medical therapy, and they're unsure what the optimal management plan should be in this group of patients. And this is because the outcomes in this cohort haven't been previously described. So that was exactly what the aim of our study was, to describe the long-term outcomes in patients with CCS with FFRCT positive stenosis who are asymptomatic on medical therapy and hence were deferred angiography and revascularization. So this was a retrospective single-center study. We collected data from over 6 years using electronic medical records to access demographic, CTCA, and outcome data. We used distal FFRCT, which is the lowest FFRCT value, distal to a stenosis, as our value for whether a stenosis was positive or not. Subsequently, we also looked at lesion-specific FFRCT, which is 2 centimeters distal to a stenosis. Our inclusion criteria was anyone who had a CTCA and FFRCT for chronic coronary syndrome and had not had a previous MI or angioplasty. We excluded those where CTCA and FFRCT was requested for other indications other than CCS. In our center, the reporting cardiologist, upon review of the CTCA, FFRCT, and medical history, would either recommend medical management and review for symptoms in clinic, or medical management and proceed directly to angiography plus minus revascularization. As a result, patients were categorized into 4 groups. Group 1 was those who were FFRCT negative, 2, those that were positive but asymptomatic, 3, those that were positive and symptomatic, and 4, those that were positive and directly recommended invasive angiography because of high-risk anatomy. Patients in groups 1 and 2 were managed medically. In addition to medical management, patients in groups 3 and 4 were directly recommended angiography plus minus revascularization. The primary outcome was a composite of unstable angina admission, which required urgent revascularization, non-fatal MI or all-cause mortality, and secondary outcomes were a composite of non-fatal MI or all-cause mortality, and each individual component of MACE. The mean age in our cohort was 62 years, and the majority of our patients were male. Our median follow-up length was 3.5 years. Most patients presented with typical angina. Over 6 years, we collected 801 CTCAs that were referred for FFRCT analysis. We excluded 246, mostly because FFRCT was not available or because they were requested for other indications other than CCS. This left 505 CTCAs with FFRCT analysis, of which 145 were FFRCT negative. Of those that were positive, 410, 240 were recommended medical management and review in clinics, of which 174 were ultimately asymptomatic and deferred angiography, and 74 were symptomatic and were in group 3, and 162 patients were ultimately recommended elective angiography to begin with. This is a table showing our primary and secondary outcomes in our 4 groups of patients. The first row is the primary outcome of unstable angina admission requiring revascularization, non-fatal MI, or all-cause mortality. As you can see, there is a statistically significant difference in the rates between groups 1 and 2, which is 3.4%, and groups 3 and 4, which is 14.9% and 17.9% respectively. So it's much lower rates of the primary outcome in groups 1 and 2. We looked at secondary outcome of a non-fatal MI or all-cause mortality, a harder endpoint, although there was a trend towards lower rates in groups 1 and 2, with 2.1% and 3.4% versus 8.1% and 6.8%. This was ultimately non-significant with a P of 0.095, suggesting most of the differences in the primary outcome were driven by differences in unstable angina admission, and this was statistically significant. I'm sorry, there's a problem with my first Kaplan-Meier curve. My second Kaplan-Meier curve shows although there was a trend towards divergence in the groups at 28 months between groups 1 and 2 and groups 3 and 4, there were ultimately late outcomes in the group 2, the patients that were asymptomatic, which meant there were no differences in the log rank test between the Kaplan-Meier curves. Of the 410 patients that were FFRCT positive, 288 were lesion-specific positive, and 122 were only distal FFRCT positive. We looked at the primary outcomes and secondary outcomes of those 2 groups as well. As you can see, lesion-specific, there was a much higher rate of primary outcomes in those with lesion-specific FFRCT positive, and this was statistically significant, as well as increased rates of a 2-point MACE in those with lesion-specific FFRCT positivity. In conclusion, those that were FFRCT positive and asymptomatic had similar rates of a 3-point MACE compared to those who were FFRCT negative. Those that were in group 2 that were asymptomatic had lower rates of 3-point MACE, as well as in group 1, compared to those who were symptomatic and those who were referred for angiography. There was a trend towards lower rates of 2-point MACE in groups 1 and 2, but this was not statistically significant. And lesion-specific FFRCT positivity is a more sensitive predictor of 3-point and 2-point MACE than distal FFRCT positivity. Our strengths, I think it's a novel idea. It's the first study to incorporate symptoms and FFRCT data to record outcomes. We had a long follow-up period, which rivals much larger registries, and limitations of the single center design and the differences in baselines but characteristics between groups. In conclusion, our data suggests it's safe to defer revascularization in this cohort of patients, but larger prospective trials are needed for confirmation. Thank you for listening.
All right, thank you for your nice presentation, and we'll have now 5 minutes for questions. Okay, all right, Dr. Juan.
Hello, terrific presentation, Juan Battle from Penn Medicine. I had a quick question about the distal FFRCT. How much judgment and subjectivity was used in determining whether or not a patient was FFRCT positive? did you determine, like if a distal tip LAD lesion was 0.79, was that called positive? How did you adjudicate those? And isn't there a pretty high proportion of distal FFRCT positive patients in your entire FFRCT pool? Doesn't that kind of influence the overall makeup of that group and therefore their results? But terrific.
Yes, of course. FFRCT was initially designed as initially adjudicated based on distal FFRCT. So all of the initial preliminary trials were based on distal FFRCT. And we used the definition based on the original trial. So anything that was positive in the distal vessel, distal to a stenosis. So we wanted to look at that specifically as well, lesion-specific versus distal FFRCT, because there's no specific guideline recommendation about which to use. Expert consensus recommends using lesion-specific FFRCT, but as I just mentioned, the basis of FFRCT was based on the initial trials on distal FFRCT positivity.
Terrific paper.
All right. So one question, and when you do retrospective studies, I mean, how certain are you about the asymptomatic status? How good is the documentation in your medical record that this patient is truly asymptomatic? And what was that potentially the indication for referral for coronary CT angiography and FFRCT
Exactly.
to start with?
Yeah, so that's a great question. The important thing to mention is that they're asymptomatic on medical therapy. So they may have been symptomatic in the past, and they were all symptomatic because that's why they presented to the rapid access chest pain clinic. But they have been rendered asymptomatic on medical therapy. I assessed this by looking at the online records and the online documentation and seeing what the clinician deemed whether they were positive or not, symptomatic or not. We didn't do any functional tests to assess symptomatology, which is a possible limitation, although it is reasonable to assume that the same level of functional status that made them symptomatic to attend the rapid access chest pain clinic meant that they were asymptomatic on follow-up.
Okay, and one last quick question. In terms of location of the plaque itself, the lesion, did you see that these asymptomatics tend to have more side branch vessel or distal vessel kind of lesion?
That's a good question. Looking at, I do have data on the exact location and severity of the stenosis of patients in the asymptomatic group, which I wasn't able to present. But it's important to note that these weren't just mild stenosis in pedally side branches. There was a significant proportion of severe, moderate to severe, and moderate. Over 70% of our stenosis were over moderately stenosed, and a portion were in the main either LAD, RCA, or circumflex arteries.
Last question to Dr. Trong in the last minute.
Yes, great presentation. I'm curious because you did a binary assessment for FFR as positive or negative. Did you compare the gray zone of the 0.75 to 0.8 area compared to negative or compared to positive?
We didn't substratify on that, and that's something that we're looking to do in FFRCT as a continuous outcome, as well as we're looking to do looking at other characteristics of FFRCT, such as delta FFRCT, which is the degree of change of FFRCT across a stenosis. But that's a really good question, and it's something that we didn't do on this study.
Yeah, I think that would be very important to do the translesional gradient as well as include the gray zone.
Yes.
All right, thank you very much. We're going to move on to the next presentation by Dr. Philippe Castello from Mount Sinai, from University of Toronto, Toronto General Hospital, and the presentation is about the association between long-term fine particulate air pollution exposure and cardiac CT coronary artery calcium score.
Hi everyone.
Dr. Castello.
Thank you, Dr. Malak. I just want to confirm that you are seeing my screen.
Yes, we can see your screen and hear you loud and clear.
Okay, thank you. So, good day, everyone. My name is Felipe Castillo. I'm one of the Cardiothoracic Imaging Fellows at the University of Toronto. I'm going to present our research on the association between long-term fine particulate air pollution exposure and cardiac CT coronary artery calcium scores. As a background, we know from prior evidence that exposure to fine particulate matter air pollution is associated with cardiovascular disease. And although the exact mechanisms are unclear, some proposed mechanisms of this damage include systemic inflammation, oxidative stress, endothelial dysfunction, potentially leading to the formation of coronary plaques, calcification, and stenosis. Prior studies have evaluated the relationship between various air pollution exposures and coronary artery disease with disparate results. Some research have shown the association while other research don't. So the purpose of this study was to evaluate the relationship between moderate long-term fine particulate matter exposure and the extent of coronary artery calcium and to identify higher risk patient groups. We designed a retrospective multi-site study. We included adult patients at intermediate risk of coronary artery disease who underwent outpatient cardiac CT for coronary artery calcium score at one of 3 hospitals between the dates of January 2012 and December 2023. The exposure, how we measured the exposure for each patient, we calculated the mean daily concentration of fine particulate matter in the 10-year period to the acquisition of the cardiac CT based on direct measurements. We have in Ontario this system of 38 monitoring stations. So what we did was to take the residence address of each patient and to link that address to the closest monitoring station to calculate an estimation of how much exposure to fine particulate matter that patient had. The outcome, as I mentioned before, we wanted to check coronary artery calcium score. So we used the Agatston technique for each patient, for each exam, to calculate the coronary artery calcium score. As you know, the Agatston calcium score is a validated method of estimation of atherosclerotic burden disease, and also is a predictor of adverse cardiovascular outcomes. We use generalized linear models with negative binomial distribution and log-link function. We perform multivariable models adjusted for age, for sex, distance to the monitoring station, the CT unit, the hospital site, the year of acquisition, and the socioeconomic status. And then we perform a stratified analysis by sex, age, and symptoms to find groups with higher risk of atherosclerotic disease. So in the results, we included 11,140 patients. 52% were male. The mean age was 59 years. 61% of these patients were asymptomatic. And the 10-year median exposure to fine particulate matter was 7.5 micrograms per cubic meter. And the median Agatston calcium score was 3, with an interquartile range of between 0 and 115. We found overall that for each 1 microgram per cubic meter increase in the exposure to fine particulate matter, the 10-year exposure was associated with 12.4% higher calcium score in the unadjusted analysis and 8.9% higher calcium score in the adjusted analysis. Both results were statistically significant. When we did the stratified analysis by sex, we found that women, for each 1 microgram per cubic meter increase in the exposure, was associated with 11.3% higher calcium score. And for men, the same for each 1 microgram per cubic meter increase in exposure to fine particulate matter, we found an association with 6% higher calcium score. Both results were statistically significant. When we stratified by age, those patients who were 50 years or older, we found that for each 1 microgram per cubic meter increase in the exposure to fine particulate matter was associated with 19.4% higher calcium score. That was significant. However, for patients below 50 years, we didn't find any association between exposure and calcium score. Regarding symptoms, those patients who were asymptomatic, for each 1 microgram per cubic meter increase in the exposure was associated with 13.5% higher calcium score. That was significant. However, for symptomatic patients, we didn't find any association between exposure to fine particulate matter and calcium score. So as part of the discussion, we found that higher long-term exposure to ambient fine particular air pollution is associated with more extensive calcium score in women, in men, in asymptomatic patients, and in patients of 50 years of age or older. Some limitations of our study. First of all, the calcium score does not quantify non-calcified plaque, so we may be underestimating the actual atherosclerotic burden. The outdoor monitoring data does not account for indoor exposure. It's just the ambient air pollution or the variability in time spent outside. We assume that the patient was acquiring this exposure all the time. And also, we have to mention that a patient could have moved, could have changed residence within the 10-year period prior to CT, and we just assume that the patient stayed in the same place to get these measurements. So in conclusion, atherosclerosis may be one of the underlying pathophysiological mechanisms by which air pollution leads to adverse cardiovascular outcomes and could explain some of the variability in cardiovascular disease risk not explained by the traditional risk factors. Thank you so much for your attention, and I'm happy to answer the questions that you may have.
Thank you for a great presentation, and thanks for all the presenters for staying on time. And now this presentation is open for discussion. So maybe I'll start with a question. So why do you think the higher or the effect is so much different between men and women? It was like almost double between women versus men in terms of the rate of increase by risk.
Yeah, that's a great question. We didn't compare between we didn't do the comparison between women and women, but we can see that it's a little bit higher in women. We think that probably the effects of other cardiovascular risk factors may be more predominant. The effect could be worse or more predominant in women than in men. We don't know the cause, but we think that probably the other risk factors are more predominant in that group. Also for the symptomatic patients, also we think the same. We don't have the exact link of that, but that's one of our theories. And also we have to take in mind that we didn't calculate the non-calcified plaques. So that could be also an option that can explain some difference between women and men.
All right, Marcel, you're muted.
Yeah, thank you. Sorry, great presentation. Just two questions. First question is, did you account for any weather data? Because we know that the link between air pollution and health outcome is often moderated by temperature, humidity, and all that factors. And the second question, maybe I missed it, like you had 3 hospitals and like a regional aspect of the air pollution. What was the range in which air pollution differed between the lowest and the highest station you monitored?
Yeah, thank you for your question. So answering the second question, this was the range that we found, 4.3 and 9.2. The hospitals are very close. I mean, are not like in separate regions, are very close in the address. So we assume that there's no like very difference between the outcomes there. And sorry, and the first question was the weather, right? Yeah. So
yes, exactly.
So we have the data of the weather, but at the end we have also the direct measurement of the exposure of the air pollution. We have fine particulate matter, we have nitrogen dioxide, we have all that data. So whether the weather is doing an impact, I think we already have the result in the data, the extracted data. We didn't find, but answering your question, we didn't find any difference between the stations.
Juan.
Perfect presentation. Thank you, Dr. Castillo. I had a couple questions, one kind of along the line of what Marcel was asking about the weather. Were there attempts to unconfound the data with a multivariate regression for things like particulate matter being correlated with other things, industrial activity, population density, food deserts, other factors that may explain the higher calcium score rather than the particulate matter itself? And then the second question I have is, why do you think there was a difference between symptomatic and asymptomatic patients? Why did the symptomatic patients not have an increase in their calcium score?
Okay, see, yeah, so we didn't, that's actually a good point. We didn't study the correlation, the potential association between pollutants. We didn't do that, and we plan to do that in the next research, because we have to adjust for that. We are doing, by the way, the study of the non-calcified plaque, so that will be a good point to include this suggestion. And regarding the symptomatic versus asymptomatic, as I mentioned before, we think that probably the symptomatic patients, the weight of the other cardiovascular risk factors is higher compared to the one of the air pollution that could be explained this lack of association between the calcium score and the exposure to air pollution that we found in this study.
One last question, like how much you think there is still residual confounding in your models? Like what, I'm not sure I saw like what you adjusted for. I know that you mentioned adjusted models.
Yeah, so we adjusted for age, sex, distance to the monitoring station, the hospital site, the unit, the year, and the socioeconomic status. And that's a great question, Dr. Almala, because you can ask, for example, if we didn't adjust for hypertension, diabetes, other cardiovascular risk factors. We think that those, after discussing this, we think that these cardiovascular risk factors are more mediators, more than confounding, because that could be in the line of the pathologic mechanisms of air pollution and calcium score. So we didn't include it at the end. So we just include those as a confounders, and the other we consider those mediators. Yeah.
All right, thank you very much. And we'll move on. The next presentation is by Dr. Anna Muller, refining cardiovascular risk, reducing events using imaging-based treatment strategies from Mount Sinai Foster Heart Hospital, New York.
Hi, everyone. It's such an honor to be part of this event today. My name is Dr. Anna Muller, and I'm a cardiology-bound internal medicine chief resident. I'm excited to share our study with you today. 1 second, I'm just going to stop sharing my camera. Okay, thank you. Can you see this all right?
Yep, it's coming nicely.
Okay, thank you.
I want to start with a scenario that many of us have seen in clinical practice. These numbers are actually based on a patient I'd recently seen in the CCU myself. You have a patient who comes to see you and they ask about their personal cardiovascular risk and what they can do to stay healthy. We ask them questions about their life and calculate the ACD risk score. It comes out as low, so we reassure them. But then they return maybe weeks, maybe months, maybe a few years later, this time to the ED, having chest pain, and they're found to have an MI. And understandably, they ask, could this have been prevented? This may seem like a rare event, but actually it's not. Nearly half of all patients who experienced their first cardiovascular event were previously labeled low risk by conventional scoring systems. So what we asked ourselves, where is the disconnect and how can we improve this? Recent studies have shown that subclinical atherosclerosis exists across all risk categories and that it's a stronger predictor of cardiovascular and all-cause mortality than risk scores. So the question becomes, are we currently treating risk or are we treating actual disease? And what happens when we shift to treating patients based on the presence of disease? To explore this, we studied 1,906 asymptomatic adults with no known coronary artery disease but a positive family history, a group who's often underestimated by traditional calculators. All patients underwent imaging, either coronary CT, calcium score, or carotid ultrasound, based on their age, symptoms, and ETT results. Although all of them were considered asymptomatic at time of referral, many described subtle symptoms such as fatigue, mild baseline dyspnea, or vague GI discomfort. That had been considered non-cardiac, but somewhat raised our suspicion. For those, and anyone with a positive ETT, we performed coronary CT. Patients with no concerning symptoms and a negative ETT underwent either ultrasound or calcium scoring, dependent on their age. Lipid-lowering therapy was then guided by whether or not plaque was present. And here's our population. We had, again, 1,906 patients. We had an almost even gender split. 51, the average age was 51 years. The average ACVD score was 4, with most patients falling into the low or borderline risk group. However, imaging told a very different story. These are our imaging results across different imaging modalities. And as you can see, the ACVD score did correlate with the presence of plaque at the population level. However, on an individual level, many patients were still missed. When we added all these results together, we came to this result, which shows us that 42% of patients considered to be low risk and about 70% of patients considered to be borderline risk had detectable plaque. Yet under current guidelines, they're not recommended for lipid-lowering therapy. What this really highlighted to us is our current approach misses a substantial number of patients who are truly at risk. While guideline reserves imaging for intermediate or high-risk patient, the added value in these groups was relatively small, since they're already qualified for intensive treatment and over 80 to 90% of them were found to have disease. In contrast, the greatest added value came in the low and borderline risk group, who are not currently recommended for treatment or imaging. Imaging not only helped us identify this hidden disease, but it also allowed us to identify patients without plaque, helping to avoid unnecessary treatment. In total, 801 patients, meaning 42%, were reclassified for lipid-lowering therapy based on imaging. And here's how we treated them. If someone had atherosclerosis, we had an LDL goal of under 70. If someone had no atherosclerosis on imaging, the target LDL was under 130. And here are our outcomes. During an average follow-up time of 4 years, only 2 patients had myocardial infarctions, both of them in the group with plaque. No events occurred in patients without atherosclerosis. We had 0 deaths, strokes, or unplanned revascularizations. To understand the impact of the strategy, we compared this observed event rate, again, 2 MIs, to what we would have expected under usual care. The different methods, we modeled expected events in 5 different ways. The first way was through the ACVD risk score alone. The second one was the ACVD risk score times 2 to account for family history. The third method was the ACVD risk score plus statin effect adjustment for guideline eligible patients. We used a prevent calculator. And finally, model 5, we used our patient's actual plaque burden to predict expected events. For that, we used data from these 2 studies that linked patients' calcium score and their CAD-RATs to event rates. For each model, we calculated annualized risk per patient and multiplied it by their follow-up time. Across these models, we predicted 30 to 104 expected events. However, we only observed 2. That translates to a relative risk reduction of 93 to 98%, and the number needed to treat ranging from 67 in Model 1 to just 12 in Model 5. And here's what this looks like on the Kaplan-Meier curve, which again highlights the superiority of this imaging-guided approach compared to our current standard methods. So what does this tell us? Overall, our study highlights the power of imaging to improve risk stratification and guide safe, effective prevention. When we treat based on risk scores, we miss disease, but when we detect and treat actual disease, we can prevent events. Imaging allowed us to detect subclinical disease missed by traditional ACVD risk scoring. It allowed us to personalize treatment intensity. and it allowed us to achieve remarkably low event rates. This marks a possible shift in prevention, moving from risk estimation to disease detection, a strategy that we feel deserves more research studies in the future. Thank you so much.
Thank you for the great presentation, and this presentation is open for discussion. So my question to you is that you included multiple imaging strategies, but then you put them all in one group. Yeah. Obviously, we know that different imaging modalities have different sensitivities and specificities for detecting plaque and others. And especially that even the carotid, I mean, the plaque in the carotid is very different than the plaque in the coronaries. So how do you account for that in terms of the overall management guidelines for these patients? Did you weigh in the same for a carotid plaque versus a coronary plaque?
Yeah, we weighed that the same way. We felt that, we were risk stratifying those patients based on the ETT and those symptoms. So based on that, we chose the imaging modality that we felt was the most appropriate. But yeah, there's differences in that. I agree.
Now, the other question, until I get more questions from the panelists, in terms of how it's easy to kind of recommend management strategies for patients, but how easy is it to achieve these very high, very ambitious targets that you had in your study? How often did these patients achieve an LDL less than 70 and others in your group?
So that was an interesting point. I personally, I'm an internal medicine resident, but I do think, showing a patient an imaging study of their own heart, I think that has great power in convincing patients to be more compliant in my own personal experience. But we were actually quite successful. We had regular follow-up 6 to 12 months, or those that were not as compliant or the LDL was higher, we included every 3 months. And we achieved a reduction of target LDL of those with an LDL target of under 70 in 63% of patients, and under 130 of those without plaque in 84% of the patients. So we were quite happy about that.
Excellent. Thank you very much, Dr. Muller, for a great presentation, and we'll move on to the next presentation by Dr. Tran from University of Sydney, and Dr. Tran is gonna present on restratifying cardiovascular risk with non-calcified plaque volume, a pilot analysis using data from the BioHeart study. Dr. Tran, the floor is yours.
G'day. Thanks for inviting me to speak at this. It's an honor. And I'm from, my name's Tuhao Tran. I'm from the Imaging and Phenotyping Laboratory under Stuart Grieve at the University of Sydney, Australia. So the title of my talk is Beyond Calcium, Restratifying Cardiovascular Risk with Non-Calcified Plaque Volume. It's a pilot study from the BioHeart registry. Sorry about this. So by way of introduction, coronary computed tomography angiography typically uses the coronary artery calcium score to semi-quantify atherosclerotic burden. The CACS obviously does not account for metabolically active non-calcified plaque, and this is a known predictor of major adverse cardiovascular events. Non-calcified plaque volume, if it can be quantified, should improve cardiovascular risk factor stratification. And this is probably more so the case in low and intermediate CACS patients. So we had a pilot study, did a pilot study of 2,097 subjects from the BioHeart registry. The BioHeart registry is a large prospective registry with now in excess of 3,000 patients that consists of a lot of biometrics, biochemistry, a lot of clinical information, granulated, as well as omics and CT studies. The non-calcified plaque volume was explicitly calculated by subtracting the total calcified plaque volume. Subtracting the calcified plaque volume from the total calcified plaque volume through a reproducible automated pipeline. We also employed automated AI-guided segmentation for precision and reproducibility, and we had human adjudication as part of the process. The CAC score risk ranges were simplified to low, less than 100, an aggregate of intermediate with 100 to 400, and high at 400. Framingham risk scores were also calculated as they were available for the data set. And we applied what we considered a novel non-calcified plaque volume threshold that was akin to the CAC's risk ranges of less than 100 millimeters cubed being low, intermediate being 100 to 400 millimeters cubed, and high being greater than 400 millimeters cubed. And we introduced that. So the results were as follows. When you plot the non-calcified plaque volume versus the CACs, you see that there's a high variability of the non-calcified plaque volume across all the risk categories, but particularly in the low and the intermediate CACs, you see that there's a considerable amount of non-calcified plaque volume, even with CACs 0 patients and the intermediate risk. Now, if you use conventional clinical risk scores, the Framingham risk score, for instance, it's not very distinguishing, not very useful in segregating. So there's high variability both with the non-calcified plaque volume and the CAC score. And you can see that there's a cluster of low-risk Framingham scores when it comes to low calcium plaque volume and low CAC scores, which is anticipated. However, with high Framingham risk scores, you see them occurring at low and intermediate CACs. So what we thought was that there's a discordance between CACs and non-calcified plaque volume. And when you looked at the high risk group, the coronary artery calcium score high risk group, about 1 to 2% of the high risk CACs group were downgraded to intermediate low risk using the non-calcified plaque volume based risk group. So there was 4 of the 204. Conversely, in the low risk group, 34% of the low risk CAC space group were upgraded to intermediate or high risk. So the 426 in intermediate and 65 in high. So in conclusion, incorporating non-calcified plaque volume into CCTA protocols in the future with a standardization with automated imaging and AI-enabled segmentation might improve risk profiling. Our novel non-calcified plaque volume risk categories need formal validation, which is currently in play with our BioHeart registry with MACE follow-up. And non-calcified plaque volume has the potential to shift the paradigm for risk categorization in coronary artery disease and change clinical practice, particularly in cohorts with low and intermediate cardiovascular risk. Thank you. I'd like to thank my collaborators, particularly Professor Stewart-Grieve.
Thank you very much for your kind presentation, and it's now open for discussion. And Marcia, you have the first question.
Okay, thank you. I have actually 2 questions. The first is kind of probably a 2-part question. The first one is, what kind of AI tool did you use to measure the plaques? And the second to that, still part on how you measure the plaque, is whether there was any visual adjudication of whether what AI is doing is correct. Some of the tools are known to be overly sensitive, but not necessarily as specific. And there's some concern, especially some of the very, very high volumes of plaque you saw in calcium score. They're exceedingly rare, like more than 2,000 volumes. So how much did we adjudicate if these are correct? And the second, which I think is the most important question, is regarding the cutoffs. It's very easy to say I reclassified to higher, but do you have any data to suggest that your cutoffs of 100 or 400, whatever it is, are meaningful cutoffs for the non-calcified plaques? Because maybe the cutoff is 300 and then you're not reclassifying that many people. So how do you define them? What is intermediate and what is high for the non-calcified plaque? Is there any clinical outcomes data to support that?
Yeah, I think I'll go backwards and I'll answer your second question first. And the answer to clinical outcomes for those thresholds that we set are not yet. And I guess it's we use the thresholds as they aligned with the CACS thresholds, knowing that the low attenuated plaques, the fibrofatty and the fibrous plaques, they would all be less than 130 Hounsfield units. And I guess when you're normally calculating the CAC score, you multiply them when the Hounsfield units are higher. Looking through the literature, there was no standardization for non-calcified plaques in terms of what's clinically significant and what wasn't. So we thought the most reasonable ranges to choose was that, and they move in accordance with those thresholds that we set. And so the MACE outcomes are pending. In terms of the artificial intelligence and human adjudication, so the technology that we used for the predominant amount of the calculations was from Siemens Healthineers, and we manually adjudicated the two adjudicators, myself and my colleague, using the MEDIS software. And so we basically went through section by section and drew the contours around the plaques for a number of vessels. We did inter-rata and intra-rata, and we developed the protocol, standardized the protocol, checked the protocol against each other, and oversaw each other. And there was a decent, I guess, inter-rata comparability. What we found that was interesting was that when we did the protocol and we developed it, we used the intuition of an interventional cardiologist where we demarcated the actual plaque. So we did the most stenosed part of the plaque, and then we did the distal and proximal edge of the plaque, and then we picked the most normal part of the plaque where you would normally land a stent, and then we calculated the plaque within that space. And we found that there was a kind of a disconnect between that calculation and the calculation we were getting from the Siemens, and we were curious as to why that was happening. And we found out that what was likely happening was that the Siemens AI calculations were actually calculating across the entire vessel. So obviously the AI is sophisticated for maybe the concentric circles, but it draws an inner and an outer, but it doesn't demarcate the plaques like we do as humans. And so when we pulled out the markers to the edge of the vessels, we found there was a good concordance with the actual results with the Siemens. So I guess it's important what the internal thresholds were by whichever company that you use as to what they decide that is calcified and uncalcified plaque. And what we found was what we did in terms of our protocol was comparable to our colleagues in the States, because we visited them and had a look at it.
Okay. And this is a common problem for all these non-calcified plaques, especially among those patients with lower calcium scores. So can you tell us a little bit more in 1 minute or less, who are those patients that had so much non-calcified plaque but low risk calcium scores?
Yeah, so whether it be a lipoprotein little a patients or the 50% of patients that have STEMIs with no conventional cardiovascular risk factors, I think it's important that we have the Framingham study based, in the 1940s and 50s, but we need to upgrade that to a better phenotyping of cardiovascular disease with our more modern imaging techniques like photon counting and characterization of plaque that, it can be better characterized.
All right, thank you very much for an excellent presentation. We'll move on to the next presentation by Dr. Joel Lennell from Cedars-Sinai Medical Center. The presentation is intensive medical treatment reduces non-calcified plaque composition in women with non-obstructive coronary artery disease, insight from AI-enabled plaque analysis and the Warrior Ancillary Serial Study.
Wonderful, thank you very much. Can you see my screen?
Yes, we can see your screen and hear you loud and clear.
Excellent. So my name is Joel Lennell, and I'm a Swedish cardiologist currently doing a postdoc with Dr. Day's lab at Cedars-Sinai in Los Angeles. It's an honor for me to present the first findings of the Warrior Ancillary Serial Imaging Study. And let's see. There we are. I have nothing to declare. So for some context before we get into the ancillary serial imaging study, I just want to let you in on the main Warrior trial that was presented at the ACC earlier this year as a late-breaking clinical trial. So in this trial, nearly 2,500 women with suspected ischemia with non-obstructive coronary arteries, known as INOCA, were randomized to either intensive medical treatment with statins, RAS inhibition, and aspirin, or to usual care at the discretion of the treating physician. So both arms were followed up until 5 years with respect to a combined MACE of time to death, MI, stroke, or hospitalization for heart failure or worsening angina. And with respect to this 5-year MACE, this trial was neutral, meaning that there were no differences in the two treatment arms. And this brings us to its cousin study, the Warrior Ancillary Serial Imaging Study. And here we asked ourselves, does intensive medical treatment promote favorable changes in plaque composition compared to usual care in women with suspected INOCA? And we studied this particularly with respect to the predefined primary outcome, which was change in non-calcified plaque composition, defined as the non-calcified plaque volume as proportion to total plaque. In the ancillary serial imaging study, we enrolled participants from the main Warrior trial, and they were selected based on certain criteria here on the right. You can see that they had to be scanned in Los Angeles or at the University of Florida, and they needed to be scanned with good image quality and have present plaque on their first CCTA scan for us to be able to tell if there is a difference over time. They also, if they were assigned to the intensive medical treatment arm, they had to be adherent to that treatment. So ultimately, 96 participants were enrolled from each arm, and after exclusion of a few with poor image quality on their second scan, 2 years after the first one, we ended up with 94 participants in the intensive medical treatment arm and 92 within the usual care arm. And here we have some baseline characteristics, and I just show you this to point out that there were no statistically significant differences between the two treatment arms with respect to age, BMI, clinical history, nor with respect to baseline treatment. But what I also want to point out, and as I marked in yellow here, is that a substantial proportion of patients in both arms at baseline before randomization were already on disease-modifying treatment. And this is likely why we didn't see a difference between the two treatment arms in the main trial, because so many receiving usual care also received statins, for instance, here at 60% baseline. Here you also have the baseline plaque characteristics, and again, there are no statistically significant differences between the two treatment arms with respect to plaque volumes or plaque composition. So this is a case example of one participant. In this particular case, we're looking at a 60-year-old woman. She had a net reduction in non-calcified plaque volume between the two scans and a net increase in calcified plaque volume, and a consistent reduction in non-calcified plaque composition at minus 14.1%. So remember, once again, non-calcified plaque composition is the non-calcified plaque volume as proportion to total plaque. And this is a particularly good metric to identify small changes in plaque volumes under statin treatment, as we expect calcified plaque to increase and non-calcified plaque at best to decrease during statin treatment, really emphasizing the proportional differences between the two. And I show you this as well. This is LDL cholesterol during follow-up throughout the study. And you remember that 60% in both arms were already on statins at baseline. So we wanted to see if there actually was a biological effect from the status in the intensive medical treatment. And indeed, we can see that the intensive medical treatment here in green shows a greater reduction in LDL cholesterol at 24 months. And this difference, as compared to the usual care in blue, is sustained at 36 months. You can see that there's also a slight reduction in LDL in the usual care arm, which likely represents some crossover here. Now, we did a similar analysis looking at blood pressure over time, here evaluating the effect of the RAS inhibition. And likewise, you can see that there is a greater decrease in systolic blood pressure in the green, representing the intensive medical treatment arm at 24 months, whereas there is no decrease in systolic blood pressure in the usual care arm. This difference is not sustained at 36 months, but overall we can say that there's the cumulative burden of blood pressure has been lower in the intensive medical treatment arm over time. And this brings us to our main findings, looking at changes in non-calcified plaque composition between the two scans. And again, green representing intensive medical treatment, blue is the usual care. And you can see that there's a reduction in non-calcified plaque composition within both arms. But importantly, there is a greater reduction in non-calcified plaque composition within the intensive medical treatment arm, likely representing plaque stabilization in this case. So what drives this change in non-calcified plaque composition? Well, it seems that the increase in calcified plaque is the main driver. Again, green intensive medical treatment, you can see that there's a greater increase in calcified plaque within the intensive medical treatment arm as compared to the usual care arm. And I should point out here as well that there are no statistically significant differences within the non-calcified plaque volumes. So finally, we looked at a multivariable linear regression model with change in non-calcified plaque composition as a dependent variable. And here you have intensive medical treatment adjusted for these other variables, index PCAT attenuation, which is a marker of pericoronary fat inflammation. We have age and we have baseline total plaque as well. And intensive medical treatment is associated with a reduction in non-calcified plaque independent of these other baseline markers that were qualified from a single univariable analysis. So in conclusion, we can say that in women with suspected INOCA, intensive medical treatment reduced non-calcified plaque composition to a greater extent than usual care. And this study offers evidence in support of a medical treatment intervention to control plaque progression among women with suspected INOCA. And it offers a description of early plaque changes under intensive medical treatment that may precede long-term differences in longer-term outcomes within the main trial. So with that, I just want to thank the team, Dr. Day, and all the co-authors, along with patients that made this study possible. Thank you very much.
All right, thank you for an excellent presentation, and this presentation is open for discussion. I'll probably start with one question. Can you describe a little bit again about the non-calcified plaque quantification? Did you look at just areas that has visual plaque, or did you look at the entire vessel lumen from the ostium of the vessel to the distal segment of the vessel?
Yeah, so it was throughout the entire coronary tree within the main vessels. We set the proximal center line at the ostium and the distal center line distally. And so we've quantified all the non-calcified plaque.
And I'm assuming these CTs were interpreted blinded to which group these patients were in the main trial.
That is correctly assumed, yes.
Okay, Dr. Trunk?
Yes, the serial scans, were they done using the same scanners and the same parameters, like the same KV, etc.?
Yeah, so according to protocol, each site was instructed to use the same scan and scanning protocol, but we haven't been able to follow that up just now. But they were supposed to. I should also point out that the autoplaque, the software we're using, also adjusts the threshold for non-calcified plaque based on features within the blood pool to adjust for KVP and in contrast intensity.
Yeah, but I think it would be very important to make sure you have that data. because you'll get, I think that's with serial scanning, definitely with improved scanners, you can definitely make the plaque go away or decrease, etc.
Any other questions from the group? So I'll ask you also one more question related to the achievement of target therapies. Did the group that had lower plaque burden, did they have better control of the risk factors in addition to the LDL? What about their blood pressure control, weight loss, newer medications for weight loss, and others? Did you notice that that group had better achievement of medical therapy targets?
So we haven't run those additional sub-analyses. We have a pretty, limited sample size at 196. So we haven't looked at that, is the short answer.
Okay. All right. Thank you very much. And we'll move on to the last presentation in this session, and it will be presented by Dr. Carrie Burns from South Metro Fire Rescue in Colorado, and this is going to be about shift change utilization of coronary CTA for cardiovascular risk and screening in firefighters. Carrie?
Yes.
I think you wanna change the display setting because we're seeing your presenter note.
Right.
So if you click on display setting or share the other monitor.
Should be. There we go.
Yes, we see it.
How does that
Yep,
look? Looks good?
yes, we see the correct one. Go
Okay.
ahead.
Great. Thank you for that introduction. And I also want to express my gratitude to the panel for the invitation to speak today. And as you mentioned, I'm Carrie Burns from Denver, Colorado area. I'm not a cardiologist, but I am the district physician for South Metro Fire Rescue. And today we're going to talk about one of my favorite topics, firefighters and their hearts. Let's see. So first, some background. Every year, the National Fire Protection Agency issues a report on line of duty fatalities. Last year, it was reported that 40% of all line of duty deaths were secondary to sudden cardiac death. Of those, 80% were due to significant underlying cardiovascular disease. Another entity to consider is that of non-fatal MI. Certainly, this occurs more frequently than an actual line of duty death, but it also has significant impact for the organization. It represents lost time, adverse impacts to staffing, and to the firefighter, it could end up with early medical retirement and disability. So the question that I face is, how do I find a screening that is, number one, accurate, and two, impactful for this group? Firefighters are strong people with strong opinions. In general, they're adverse to medical evaluation because, like military personnel, police, aviators, an evaluation could equal a condition that either makes them non-operational for a period of time or even leads to job loss. So here at South Metro, we partnered with a local cardiology group, and we chose to use CCTA with quantitative plaque analysis as part of our screening program. We then tied this to their annual occupational physical. We made it available to those who were 40 years and older. And if you were younger and had cardiovascular risk factors, you could be included as well. I do want to make a note that although the occupational physical is mandatory, participation in this screening program was optional. Further components of the screening program included evaluation of cardiovascular risk factors, laboratories. We calculated prevent risk scores. In addition to the CCTA, we used a commercially available AI program with Clearly Labs. calcium scoring was also performed. And I think one of the biggest components of this was each and every line member then met with myself or the physician assistant to review all of their data and come up with individual prevention plans. So we had 309 line members raise their hand and participate. As you can tell, the vast majority were male, and they had a median age of 47. When we look at the baseline characteristics of this group, I would just like to point out that in general, these are young, healthy people who do indeed have some cardiovascular risk factors, but they're really not considered to be high risk for heart disease. We have a very low rate of smoking, low rates of diabetes. And one last thing is that if you look at median years of service, it's 22. So I would indeed consider this group to be career firefighters. So let's take a look at what we found. Medium calcium score was 0 for the group. We did have 106 with CAC scores greater than 0. And I would like to point out that in our CAC 0 group, 83% had non-calcified plaque. 2 of the firefighters of that group had stenoses greater than 50%. So in my opinion, this further highlights the importance of CCTA for early detection of heart disease in this group. And then when looking at the CCTA and quantified plaque results, we had 28 line members who had significant plaque burden with PAVs 5% or greater. 12 had stenoses greater than 50%. 11 ended up being referred to intervention. 9 underwent successful PCI. But in all of these numbers, I think the most important one is the one at the bottom. 88 were referred to preventive cardiology and actually attended their evaluation appointments. As mentioned before, we calculated prevent risk scores. We did have 278 firefighters with plaque on CCTA, but the prevent score underestimated the risk for these individuals, with only 13 having scores of 5% or greater. Now, what I would like to do is jump from data into the human factor, and I want to talk about one pertinent case. This gentleman, 50 years old, career firefighter, no family history of heart disease. He did have hypertension controlled on medications. He did not take a statin for his LDL. He did not have diabetes. He never smoked. His A1C was 5.5 and prevent score of 6. So his scan results look like this. He had extreme plaque burden with a PAV of 11.3% and a 71% stenosis. When you talk to this individual, his only actual complaint was that when he was in full bunker gear, which adds another 60 to 70 pounds, and climbing stairs, he felt that he was getting more short of breath than usual. But he dismissed the symptoms because he had just turned 50 and thought that it was part of aging. He went to the cath lab, was successfully stented, and now he's on aggressive medical management and working full-time. I'd like to add that his son is a new candidate and going to start our academy in July. In conclusion, I would say that CCTA with plaque analysis for us was a very accurate tool in detection of heart disease. Non-calcified plaque was very common, and again, highlighting the need, the importance of CCTA for this detection of heart disease. And in our group, prevent scores frequently underestimated the risk in this population and could have resulted in delayed prevention strategies. So what is the future? And in my opinion, I feel that the future is quite bright. We're continuing our screening program. We are gathering 1-year follow-up data on last year's group. But I do recognize that in spite of our extensive benefits, there are certain challenges, one of which is the cost of the program. We also have to be quite thoughtful about radiation dosages and mindful about management of incidental findings. Last but not least, I would like to thank the entire team, because without them, this program would not have been possible. And with that, I'll take any questions.
Thank you very much for an excellent presentation, and we'll open it up for discussion. So I'll start with one question that we kind of touched on the prior presentation, which I think the very high non-calcified plaque burden among patients with zero calcium score, which technically almost all commercial software have this tendency to overcall plaque. And it looks like if I read it correctly, you had 83% of patients with zero calcium score have some non-calcified plaque. That's very high, at least in general, especially compared to the low risk cohort that you have. I mean, diabetes in your cohort is like less than 5%, smoking or hypertension in single digits, and still having this much high non-calcified plaque appears to me a little bit very high in this kind of cohort.
Sure, and what I can tell you is that we have now made all of their images available to the team at UVA, and they are currently reviewing all of these scans. So I expect there may be some adjustment to the data, but this is what I know at this point in time.
Okay. Marcel?
Thank you for the excellent presentation. Very interesting topic. Just one question, because I don't know that much about it. How is the routine cardiovascular checkup for firefighters? And did you address the findings of your study in any case?
So, okay, I'm not sure that I understand the last part of your question.
Sorry, do you adjust the routine checkup based on your findings? Because the non-calcified plaque, usually if you do only a calcium scoring, it's not covered. So
right, and I'm really sorry. I think I'm just not quite.
I think the question is, how did you get a CTA and a regular checkup of a was the CT a clinically indicated CT, or was it a pure research CT?
It was pure research, absolutely pure research. Yes.
So it was not part of the clinical routine for your yearly checkup of firefighters in your practice.
That's correct. Before this, we had another program for assessing cardiovascular conditions that include an echo, carotid ultrasounds, and IMT measurements. But we chose to go ahead and institute this as our primary cardiovascular screening.
Okay. And maybe I'll finish up with one last question is, in terms of these patients for who underwent PCI, most of them were asymptomatic based on this, right? I mean, or except for the one that you shared who was having some dyspnea on exertion, on maximal exertion.
So I think that's what makes this group really, really unique. These are in general very high performing group. And I know one of them, like in talking with the interventionalist about this, one gentleman, we do an annual MET score, and his MET score is 15 or 16. And the complaint that he gave to intervention was that when he was mountain biking at very high altitudes, again, he felt that his performance wasn't as good. There were some very subtle symptoms. So none of them overtly were having chest pain or, feeling terrible. It was these are high performers who noticed declines in their performance.
All right. Any other questions from the panelists? All right. Seeing none, we'll move ahead and close the session. I want to thank all the presenters for excellent presentations. I want to thank all the panel members for great discussion and great discussion as well as engagement. I want to congratulate all the finalists for being part of this session and remind you that the results will be announced during the SCCT 2025 meeting in breakout room number 1, 210A at 11:30 to 12:45 on Saturday, July 19. and looking forward to seeing everyone in person in Montreal on SCCT 2025 between July 17 and 20. Thank you very much, and looking forward to seeing everyone in person.